You still have the problems. You got too much disease. The solution, I liken it to iron lungs. You know, dentistry is in charge of polio. We'd have better iron lungs, fancier iron lungs that work better, but we'd still have iron lungs. We really need to think about why is it we have too much disease, and it's not because we don't have enough dentists to fix our teeth, because the system of going to having a dental home works. The problem with it is disease is so overwhelming that there's too much to fix, and there's a disconnect. And so we have to have is a different way of looking at it. You have to look at, okay, how do we, first thing you have to do is a system to manage people's pain. Where do people show up with their problems, and how do you have an after hours call system or some kind of call system that deals with people in pain, and then gets them to the place where their pain could be taken care of. So in our system, we emphasize almost like a MASH unit. Be available, be open and available for people to show up. And very frankly, you can't do that if you get paid for the bigger the procedures, because you don't have the money to be able to apply it in a way where you can actually be there when the people need you. So what most dentists do is they avoid taking emergencies because they're not productive, because of the fee-for-service system. But in a capitated system, you're then able to provide the emergency care you need, and organize your clinics in a way where you can take care of the patient's need, not the dentist's need. You can address both. You have a system to where when somebody calls with a problem that day, you can get them in and get them taken care of so that they don't use the system inappropriately. And that is go to the hospital ED and get prescriptions and pain pills. More prescriptions you give people for a dental infection, the greater chance they are to get an infection that will be life-threatening. What I mean by that is cavernous sinus thrombosis and Ludwig's angina, those things that are life-threatening, increase in risk when you give people more than one dose of antibiotics, because they become resistant, and the bacteria, they become more virulent bacteria, which ends up causing them with more life-threatening disease. And so you got to have a system that allows you to see people when they have the problem, almost walk in. At least the problem with walk-in is that they walk in when you don't have time for them, they have to wait, and then they get upset. So what you need to do is have them call in and then have them come that day in a time that makes more sense, and then tell them that they might have to wait because you're squeezing them in while you're doing the other stuff that needs to be done. Because very frankly, the population wants to not hurt, not have to spend a lot of money, and be able to smile. And so a piece of what dentistry has to do is create smiles. And if you don't create smiles, people get upset also. And so you have to have a balance between creating smiles and taking care of their felt need and taking care of their disease. And you have to be able to manage what the people want, or what they've been taught, and what they don't realize, what they've been taught, and what it is that they need. So it's a deal between what they want and what they need, and you got to have a system for that. So to break the cycle in children, what do you do? Well, there are new, I think I finally figured out where I left off, is there are new technologies. And there are new technologies that we can use, because the technology of the drill and the filling doesn't work in this population, which you've already illustrated, and I think by this time have shown you really isn't going to work. So because we were able to fund ourselves in a different way, we were able to take some of the money and to do R&D, research and development, and look at the literature and look at the science, and then begin to look at things that try things and hire people to help us. Basically, we've been involved in some studies and some research and some programs that we tried to look at some of these things. And because we get a block of money and we can allocate some money to that, we began to look at different technologies. One of them was, the early on one was xylitol. The studies show that if you give xylitol, the 5-carbon radical sugar, the bacteria in the mouth that cause the infection can't use the 5-carbon radical for food source, and therefore it basically starves them to death. Now I'm oversimplifying, but it basically starves them to death. They're less of it, and then what happens is, because the waste products that come from those bacteria, which is the ammonia-like compound and the acid, doesn't produce, and therefore the biofilm it causes less harm. Interesting study they did in the Scandinavian countries, back in the day where they actually gave mothers of newborns xylitol 6 grams a day, and they basically reduced the amount of tooth decay in the children at age 5 by 75%, and they didn't do anything to the children. They just lowered the amount of infection in the moms of newborns by using xylitol, and they reduced the amount of tooth decay in children at age 5. And there's a lot of controversy around xylitol and whether it works or doesn't work, but there's also a lot of controversy around the studies they did and whether were really good studies. But the truth is, xylitol works. You give xylitol to moms and newborns, and their kids have less decay. And the reason it does it is because it inhibits the growth of the bacteria that causes the problem, because they can't use it as sugar. Xylitol is also really sweet, doesn't take a lot of it, and therefore it's a product that works. And we used that first. And we did some work down in Klamath Falls in this Robert Wood Johnson grant, where we actually got pregnant moms in, got their disease, we fixed their teeth, got their disease load down, we cleaned their teeth, we get them on fluoride toothpaste bedtime. We got them on the xylitol. Basically, we gave them xylitol when their kids were born. We got them in, and we did a series of interventions. We got the children in early and did a series of interventions. We did this over 567 moms. One thing we did by using case management, we were able to cut the no-show rates of these pregnant moms, pregnant women and their children from 40% to 9%. And we were able to lower what we found was when we looked at the 2-year-olds, the ones we could gather up that went through the program, they, in Klamath County, they had, when we compared those to 3 counties, Deschutes, Jefferson, and Crook, is what we found is they had 50% less decay. And so we knew that the key piece was the pregnant women and their children. So we took that work, and we began to implement that into our company. How do we take this research we did, we know works, and implement it into a system that works, that we can actually put in, train our providers, train all of our staff, have our systems support, and the whole thing. The problem with it is we still had too many cavities to fill. And what do we do with the cavities? Is there any way? And so I asked Milgram ask him a question: is there anything we can do? Is there anything we can do to arrest the decay, stop the decay without doing a filling? And he says, yeah, silver fluoride. Yeah, silver diamine fluoride. And I mean, interestingly enough, when I was in dental school, I'm old enough to where I was taught silver nitrate, the silver nitrate technique. Well, when I promptly got out of school, I used it a couple times on a couple of cavities, but I promptly forgot it because there was insurance and there was materials, and we spent all our time fixing on people who had the ability to use the system. And I promptly forgot it. In school, they never really talked about what it did. They just said it stopped the cavity. They never talked about it being antimicrobial. They never talked about any of that kind of stuff. They just said it's a compound we have that works. You put it on a cavity, and it'll turn it dark, and very frankly, it works. But when Milgram talked about silver diamine fluoride, he gave me a whole raft of literature about silver diamine fluoride that was done in Australia, China, Hong Kong, and Japan. And so we did a whole lot of work on it. And so, very frankly, I got to talking about it, and that's about the time I ran into Dr. Duffin, who had his own journey that he talks about, and he's written articles about, and you can study. But I was developing a system, and he was developing a methodology in a clinic and how to use it.
Okay, there.
Yeah. So I ran into Dr. Duffin, and we were talking about it. Also, you can't get silver diamine fluoride in the United States, but you could get silver fluoride. You could get silver fluoride in the it's interesting story is that we were down in Klamath Falls working on the pregnant women program in the Robert Johnson grant, and he was supposed to fly out of Klamath Falls, and we got snowed in. and I had my big excursion with the four-hole studded tires and four-wheel drive, and so I said I was going to give him a ride up to the Redmond Airport. Well, so along the way we got to discussing, are there compounds we can use to stop a cavity without having to fill it? And he said, yeah, silver-diamine fluoride. So like I said earlier, he gave me a whole bunch of literature about it, and I started studying it, and I couldn't get it. What he found is silver-diamine fluoride is made in China and Japan, and it's not available in the United States unless you bootleg it in. And I didn't know about bootlegging it in, and so what I did is bootlegged in some silver fluoride. I was able to get 5 milligrams of silver fluoride and then put it in suspension, and you put it in with 40 milliliters of water. You got a 40% solution, and then we started. Some of my friends started using it. And the problem with silver fluoride is it's caustic because it'll eat right through plastic. You have to have it in glass and rubber. And the second thing that's wrong with it, it doesn't stay in suspension, so you got to continually shake it up. But it works really well. It worked really well. Well, in the interim, one of my friends was bootlegging in what they call saffuride, which comes from Japan, which is made by Morita. Was bringing it in. You could get 5 milliliter bottles, and so we started using it. Well, in the interim, that was very, none of us felt really good about it. We knew that it worked. The problem with it is my friend Steve Duffin. My friend Steve Duffin started look at Steve's a historian, and so what Steve started doing is looking at what other compounds have silver in them, and he revisited silver nitrate. And what he knew is if you sterilize the cavity, and you add fluoride, and the body picks up calcium out of the saliva, the body will heal itself. And so Steve thought, I wonder what will happen if I, part of what it is that the varnish, I think he was thinking that it didn't work as well because it was washed out, and I really think it didn't work as well because the fluoride wasn't there. And who knows? But when you add fluoride to a sterilized cavity and you add calcium to the calcium appetite, you get the body the dentin remineralizing itself. So excellent work on that was done by the fellows at the University of Hong Kong and others. And so Dr. Duffin started using silver nitrate and fluoride varnish. Well, we in Advantage Dental, we hired Duffin, and we hired Dr. Milgram to come, and I should back up. Dr. Duffin had done some work in his practice where he had seen, I can't remember exactly the number for sure, over 1,000 kids, and what he used in silver nitrate and varnish. What he noticed is fewer and fewer kids had to go to the hospital. In fact, he got to the point where almost no one had to go to the hospital to get care. He also noticed that once the cavity was arrested, he could fill it without anesthetic. Those that need, and he also noticed he didn't have to fill near as many, and mainly the ones that were didn't have to fill near as many. And he noticed that he had very few failures. Out of 1,000 patients, he had very few failures. And so we looked at that and looked at his protocol, and we started working together on a consulting basis, where he came and trained all of our providers. He actually was part of it. We hired Milgram. We actually got Milgram to come down and give a class to all of our providers, invited all of our providers in. And very frankly, most of them came. And we talked about this whole process, and we talked about the different sciences, xylitol, fluoride toothpaste, as well as silver antimicrobials. And Duffin came and talked about what he had done, the history of what he'd done and what he had found. And we then took that, Gary Allen, who was working for another managed care company, who came to work for us because of some circumstances, and Sherry Ludwig, who is our community-based, she manages our community outreach program. She's an expansive function hygienist. And Dr. Duffin went around all the parts of all over the state and trained all of our providers in this medical management of caries. And we were using silver nitrate and varnish. because silver fluoride wasn't available. And very frankly, I wonder if it makes a difference, but very frankly, there's a lot more literature around silver fluoride than there is around silver nitrate. The stuff done in silver nitrate was old, and there's not as much published research that's new, and so I don't know if it makes a difference, but very frankly, who knows for sure? That's a debate that'll be settled as time. But in the interim, we started using it, and very frankly, when we had Milgram and another fellow from the University of Washington look at our data over a 3-year period of time, we'd done over 30,000 treatments. And so we're now in the process of looking and see what impact that has. One of the things we did notice was our number of cases going to the hospital went down by almost 50%. In the face of a rising population, with more and more needs, we found that we were able to manage the disease in a more effective way by using the silver products and the medical management carries. Basically developed the protocol that was developed by Duff and all the work that he did with silver nitrate. So in the interim, we started 8 or 9 years ago trying to figure out how we get silver diamine fluoride approved in the United States. So we actually got a 510K approved by the FDA to get it approved as a device. Very frankly, we didn't have the resources to get approved as a drug because all fluorides are treated as drugs. So we felt if we got it approved as a device, a root desensitizing device, by the way, it is the most effective root desensitizing compound there is on the marketplace anywhere. It works twice as good as anything else. Now, some people might want to debate that, but it really does. You paint it on a sensitive root, and guess what? It's not sensitive anymore. So we got it designated as a root desensitizing device through the FDA, and then we embarked on our journey to get it approved. And very frankly, some of it was the resistance of the FDA, and some of it was our naivety on the process. And long story short, after 8 long years, we finally got silver diamine fluoride approved as a device in August of 2014. And they don't approve it. What they do is they clear it to market. The FDA doesn't approve devices, they clear them to market. If they approve them, then they'd be responsible for them, so they just clear them to market, and you're responsible for them. So it was cleared to market in August after 8 long years, probably 10 long years from the time the conversation started to get it approved, so we could market it. An interesting process because of all the ups and downs and roundabouts that we had to do. And then it's one thing to get it clear to market, it's another thing to be able to market it. Well, the Merida wasn't interested in the United States and their product. They just weren't interested. I think they didn't think it was a big enough market. And very frankly, I don't think they really think much about it. So we worked with Merida to get some of the raw product. We finally got them to sell us 20 liters. We brought it in, and then we had to package it. And well, there's a whole process. You have to go through the FDA to make sure that you can market it. You have to be able to track each unit that's sold, so that if something goes wrong, they can trace their way back to that unit. You have to have a system to track all of that stuff. So therefore, we looked around at people who could market it for us, and we ran into what we already knew about, to Kevin Thomas and his group at Elevate Oral Health, who had been previous experience with Omni Dental and varnish, and had been a big part of getting the fluoride varnish approved. Interestingly enough, one of the resistors at the FDA was the fact that the fluoride varnish was never approved as a fluoride treatment, preventive treatment. It was approved as a cavity varnish. Some of us are old enough to remember Copalite and the varnish we used to put underneath fillings, which we don't do anymore. But it was approved as a cavity varnish, and because that was the easiest way to get into the United States, even though they've been used in Europe for a long time as a fluoride treatment. So it came into the United States. Well, the FDA also knew that this product was probably going to get used off-label as a drug, carries arrestment product, a fluoride. And so I think that had a big part to do with our ability to get it through. Lots of history around it. I could spend a whole day talking about how we did that, but very frankly, the truth be known is we finally got it done. Advantage Dental got a grant from the business startup grant from the NIH for about $150,000. The rest of it paid for, probably $350 to $400 to $500,000 of money that it put in, plus about, I suspect, $500,000 for the Dr. Milgram's time. We formed a joint venture, an LLC between Advantage Dental and Dr. Milgram. This entity is responsible for it. Interestingly enough, if you're a small business, the cost of getting through the FDA is different than if you're a large business. And Advantage Dental Silver Arrest is a small business and a 50-50 partner between Advantage and Dr. Milgram. And eventually it got approved and we got it to market. And in April of 2015, you were able to buy an 8 milligram bottle of Advantage Arrest, called Advantage Arrest, in the marketplace. It's an interesting story around just how should we package it. You know, we looked at individual doses, which would be ideal. Very frankly, it's very difficult to do that, and so we just decided that we did a focus group, and very frankly, most of the dentists said they just liked it out of the bottle, and so that's how we developed to get it out to the market the quickest way possible. It's the easiest to fill, the filling costs were less, but then in the interim, one of the criticisms of Saffuride is the fact that some inconsistent product, and so we had some problems. I mean, I have to say the Merida people are really good to work with, but the problem with it is doing business with Japan is very interesting it's strange for Americans to do business with Japanese. And we found that doing business with them was slow, cumbersome, not very consistent, and we never knew for sure exactly what the price was going to be. It seemed like it changed day to day. So once we got the initial 20 liters, we were looking for a manufacturer to manufacture in the United States. Coincidentally, I have a daughter who is a PhD organic chemist who works for a company in Eugene, and they make stuff. They make chemicals. And exactly 1 year ago to Saturday, 4th of July, we were sitting on the back porch of the house that we're sitting in now, and we were talking, and she said, "Geez, Dad, let me go home and see if we could make that product." So she went home, looked it up, and I'm not going to tell her how she tell you how to did it, because you can figure that out for yourself. But she figured out how you could make silver diamine fluoride with the same consistency that the 40% or 39.8% or whatever it is that the Japanese were making and the Chinese were making, and they could do it on a consistent basis, and they could make it in a much easier, safer way. And so we're in the process of, but there's a whole bunch of hoops they have to jump through to be FDA certified. So we're in the process of helping them, and they're not they haven't been in the business of manufacturing things. They've been in the business of making products for other people to manufacture, and so we're helping them get into the manufacturing business, and they'll be a source of silver diamine fluoride. And we've ordered 10 milliliters of the product because we're getting close to having the first 20 milliliters sold. I shouldn't say we, I should say Elevate is. That's a whole other conversation about how did we develop a relationship with Elevate in a way where we all felt that it was a fair way to do it.
Mike, could I jump in and just re-divert you back to another part of the story, and that is the Board of Dentistry in Oregon, and what has evolved over the past 10 years in terms of the attitude of medical management caries with various products, and especially the most recent board meeting that you and I were at, which opened the doors to this treatment.
Once you have a product, and once you're using it, and once you're making a difference, is people begin to notice. And the people who notice are the people who usually are threatened, because then if you read the little book, Paradigms, the Business of Discovering the Future, the guy says that the more vested you are in your paradigm, the higher, more trained you are in it, the more resistance you have to change. And I had the opportunity, I was invited to speak at the Western Regional Society of Dental Boards and Deans of Dental Schools and Board Examiners, the chairs of board examiners in San Diego. And I went down, and Ron Short was the president of the Oregon board, and Ron Short was a principal with us. And the resistance that we had, and what he saw was the dental boards basically manage the fee-for-service system, and they are not equipped to deal with a system that's different than that. And he wanted me to come down and talk to them about what do we do if you have somebody in your chair who has a disease out of control and restorations don't work. What's ethical? In fact, I'd had the opportunity, and I asked, one of the questions I asked as we went through this is, well, if I have somebody sitting in my chair who's addicted, say maybe addicted on meth, and their teeth are bad, and I take all of their teeth out, and then they get treated, they say, well, while I was addicted, why'd you take my teeth out? And I actually had the opportunity to ask the ethicist for the University of Health Science Center in Portland, what did he think? And what he said was, that really is an ethical dilemma. And so we began to ask ourselves, well, what should we do? Well, the Board of Dentistry was coming down and hammering those of us that were doing medical management of caries because we weren't fixing the teeth. In fact, all the leadership of the Oregon Dental Association came down and testified against silver nitrate and varnish because supposedly it wasn't any science, it wasn't safe, it was a poison, and all kinds of things that they did. And very frankly, I always wondered why the immediate two past presidents, a current president, and the incoming president all stood up and said, we're against it. But then I realized that the Dental Association really represents the fee-for-service model of delivery of care, and they'd be economically challenged if we got a new system. And I thought that the Dental Association was representing doctors, not technicians. And so what we got was the Board of Dentistry saying that, yes, it could be used, but it can only be applied by a dentist. And so, but they did say that we'd look different at silver fluoride. And even the dentist said, well, it was silver fluoride, where there was more research, we might look at it different. And so once we got silver diamine fluoride approved, cleared to market in the United States, then we came back and revisited, and what the Board of Dentistry said, well, there's a fluoride, and assistants and hygienists can apply fluorides, therefore they can apply silver diamine fluoride. And so now in Oregon, it's ethical and legal for hygienists and assistants to apply it like any other fluoride. And so now we can, but like anything else, it has a safety margin that you have to be considered of, and so therefore you have to use it like you're supposed to. It's no different than, hydrochloric acid they put on teeth, it's enamel. If you don't use it, an assistant can put it on, and so can hygienists. And if you put it on or appropriate, it can burn tissue, it can do stuff, and so you got to use it within the protocol. Everything has a protocol, and you have to use it within that protocol. But very frankly, in the Board of Dentistry said, yep, silver. They still silver nitrate, still got to be applied by the dentist. But the assistant hygienist can put the fluoride varnish on, but they can't put the silver nitrate on, which is kind of interesting, but that's the way it currently stands. But they can put on silver diamine fluoride, so that's where we're at with that.
It's opening a whole new door for medical management caries with silver compounds.
And one of the things you need to know, though, is the Board of Dentistry, dentist turned a dentist over to the board because for inappropriate care. Parents took their kid with a mouthful of cavities to the dentist and said, we want our kid's teeth fixed. And the dentist said, you got a disease out of control, we need to treat the disease first. And the parent says, we know we've neglected our child, we just want their teeth fixed. And the dentist says, I just can't ethically do that. So they took the child with the cavities to another dentist. The dentist fixed the teeth without getting the infection under control and turned the first dentist over to the Board of Dentistry. The Board of Dentistry ruled in favor of the first dentist and said that it really was appropriate to get the infection under control before you fixed all the teeth. And it was not ethical. And so for the first time in the history, probably of the United States, the Board of Dentistry came down on the side this is an infectious disease and we ought to get the infection under control before we do the restorations. That's probably the key thing. And that's what I talked about when I talked before the deans and dental board examiners was in the presence of this out of control infection that you have in the Medicaid and in the uninsured population, you really need to start thinking about this different. And rather than hammering dentists that are trying to get the infection under control because they're not doing the fillings, you really need to start thinking about the fact that maybe it's unethical if you don't get the infection under control. And guess what? The guy who protests, what is the old Shakespearean, thou dost protest us too much, is the person who protested the most was the endodontist, who's the highest up the food chain, the most trained, and the most to lose if this technique worked. So that was the guy that argued with me the most. But my point being is you got to start thinking about it different in the educational systems and in the board of dentistry.